Good afternoon, everyone. Thank you to all who are joining online and in person. I would like to welcome you to Project Echo, a program that Dr. Santos and Dr. George founded. This initiative hosts monthly sessions to specialists from our Health Science Center to educate primary care providers in rural and underserved areas of West Texas. The goal is to address key metabolic and health disparities through case-based scenarios with hopes of reducing unnecessary referrals, labs, procedures, and ultimately drive down healthcare costs to our patients. You may occasionally receive emails from our Project Echo team inviting you to host a presentation or participate as a panel specialist in the future. Keep an eye out for these exciting opportunities. Before we begin, quick reminders. If you're attending online, please stay muted throughout the presentation. CME credits will be available for this event, but you may complete the evaluation survey at the end of the presentation. We will have a reminder at 12:55. For those attending in person, please ensure you've signed in on the paper at the front. This educational activity is supported by Texas Telehealth Resource Center, a federally funded program of the Rural and Community Health.
Good afternoon, everyone. My name is Christian Bell. I'm a second-year medical student here at TTU HSC, and I'll be presenting this case alongside Dr. Natarajan, a PGY4 nephrology fellow here at TTU HSC, and Dr. Zachariah, professor, division chief of nephrology, and nephrology fellowship program director at TTU HSC. And our case is regarding managing kidney transplant recipients in primary care. Pardon the interruption. So our case involves an 80-year-old male who presented to the emergency department with complaints of weakness, lethargy, and decreased oral intake for 2 days. His past medical history includes coronary artery disease, hypertension, non-alcoholic steatohepatitis, pancreatitis episodes in 2011, new onset diabetes following transplantation, end-stage renal disease secondary to hypertension, status post a deceased donor kidney transplant in 2006 at UMC. His social history is unremarkable. Past surgical history includes a radical prostatectomy, a fistula placed in the left upper extremity, a cholecystectomy in 2010, and of course, his kidney transplant in 2006. There are no known allergies. His current medications include levothyroxine, atorvastatin, aspirin, Rapamune 1 milligrams alternating with half a milligram every other day, Cellcept 500 milligrams twice daily, insulin 25 units in the morning, 12 nightly, Jardiance, metformin, glipizide, lisinopril, spironolactone, and metoprolol tartrate. Vital signs for this patient include a temperature of 98 degrees, heart rate 70, respiratory rate 18, blood pressure 124/74, O2 100%, weight 70, BMI of about 25, and a body surface area of 1.8. The remainder of the exam was not significant. His labs are shown here. I'd like to draw your attention to a potassium of 3.2, glucose of 31, creatinine of 0.5, CRP of 1.9, and a random sirolimus level of 9.9. Imaging performed on this patient includes a chest x-ray, which revealed a normal chest x-ray per the report. An ECG showed normal sinus rhythm with a nonspecific T-wave abnormality. A head CT was ordered for altered mental status, which showed no signs of acute bleeding, and a CT abdomen and pelvis without contrast was ordered for some abdominal discomfort, revealing sigmoid diverticulosis.
Thank you, Christian. And I'm going to recap some of the information that we gathered based on the medical records that we found in UMC. And so this is an 80-year-old male with a past medical history of ESKD on hemodialysis in 2005, secondary to hypertension. She received a deceased donor kidney transplant in UMC in 2006, developed a new onset diabetes after renal transplant in 2007, and subsequently developed a few episodes of pancreatitis over the years, and in 2012, and a few episodes after that as well, with unknown etiology. And he had a lab cholecystectomy in 2013, and he developed a NASH during the subsequent years, and he presented to the hospital in the last 3 months with an episode of abdominal pain, poor oral intake for the last 2 days. So these are the differentials that I want to bring it to the attention of for the primary team. we always think in terms of abdominal pain that all differentials do apply for transplant patients as well. There are some additional differentials that you have to think about when you are thinking in terms of the post-transplant patients. So when a post-transplant patient has an abdominal pain, there could be tenderness over the allograft kidney, there could be peritonitis, there could be pyelonephritis, which are very specific to the transplant-related conditions at any stage of the transplant, even acute, early stages, or now even after later stage as well. So this is something that we need to consider. The next thing is the GI side effects of immunosuppression medications. They may be having chronic diarrhea and volume loss associated with it, which can result in acute decompensation, resulting in patient getting admitted with abdominal pain, all those kind of things. And opportunistic infections specific to immunosuppression. People do develop CMV colitis, diverticulitis, and allograft pyelonephritis, which I mentioned earlier. And other things that we need to be mindful about is patient may develop over the period of time EBV-derived effects, which is they may develop lymphoproliferative disorders after the transplant, and those symptoms will present as general symptoms like weight loss, loss of appetite, and any symptoms, any cancer-related symptoms. It's not necessarily limited to EBV. They are higher predisposition to develop cancer, so we need to be thinking about that. So those are the differentials that you need to be thinking in addition to our normal abdominal pain symptoms and differentials. So this is the assessment plan that was done when the patient was here. So at that time, the diagnosis at that time was like he was found to be having hypoglycemic. As you all would have noticed, his blood glucose was around 31, and baseline creatinine was around 0.7 to 0.8. And one thing I wanted to bring it to your attention is like this patient has been following us. It's a diseased donor kidney disease, and he's been having this for the last almost like 19 years. And this is one of the most successful transplant patients that we have. And at that time, what we did when he was admitted here is we were planning to hold on the Jardians, glipizide, and insulin due to the hypoglycemia. At that time, we ordered abdominal CT without contrast, and we found that there was some diverticulosis there. And we wanted to continue with the home doses of immunosuppression medication. So anytime we want help with the immunosuppression medication comes specifically to the kidney transplant, it's better to consult us so that we can make some informed decision. So this is the assessment plan at that time. And the patient was discharged after 2 days after the admission. The primary team had a plan to make some changes to the A1C goal. That's up to them. And we discharged the patient on Jardians, 10 milligrams daily, and metformin of 1 gram twice daily. We discontinued the glipizide, 10 milligram twice daily, and the novolin as well. We wanted to advise them to closely follow up the blood sugars with the primary care and follow up in transplant nephrology clinic as early as possible within a week or two. And home health was set up at that time. I'm going to pass to Dr. Zachariah to discuss about the further slides. Thank you so much.
Thanks, Christian and Dr. Natarajan, for that succinct description of our longest surviving renal transplant recipient. So the aim of today's talk is to discuss how a primary care physician can assist with the management of kidney transplant recipients. You may ask why. Well, I will go into that. We will focus on medical issues pertaining to medical issues in the kidney transplant recipients, and will also briefly address basic aspects of immunosuppression. You may know that at this point, we have over 500 kidney transplant recipients in our country. In the past decade, there has been an increase in the number of kidney transplant recipients. There is an increase in the age of kidney transplant recipients, and also 1 year graft survival has increased. So what have we gained in the past 2 decades is, as you can see, the yellow line is the attrition of graft in 0 to 1 year. So that has actually gone down tremendously. But if you look at all the other graphs, the 1 to 3, 3 to 5, and 5 to 10 years have relatively remained stable in the sense the the survival benefit that we have gained with 1 year survival being over 95% is largely achieved by the 1 year decrease in 1 year graft attrition. And this is mainly due to triple immunotherapy with the introduction of calcineurin inhibitors. What we don't have achieved, we have not achieved is we have not achieved preserving graft function in the long term. So that remains the same. And here is why primary care physicians will become very important part of that collaboration. As the number of kidney transplant recipients is increasing, it is going to overwhelm the transplant collaborators or the transplant professionals to take care of them. And in all honesty, they are not even prepared to take care of them. Therefore, there is going to be an increasing number of kidney transplant recipients who are going to show up at the primary care physician's office. And there you go. You have to know about this, and you will be very pivotal in playing a role in preventing graft attrition. So what are the biggest causes? What are the causes of graft attrition in kidney transplant recipients? Surprisingly, the leading cause of graft loss after renal transplant is patient death, or other words called cause of death with function. So cardiovascular disease continues to lead graft attrition in this patient population, followed by infection and followed by kidney-related outcomes such as chronic rejection and malignancy. So this should surprise you that the very comorbidities that have prevailed in the patients before transplant continues to grow post-transplant. So therefore, to modify the risk of cardiovascular disease, the primary care physician will now have to focus on pretty much what are the factors that you would decrease in a general population to reduce their cardiovascular risk? Diabetes, hypertension, smoking, dyslipidemia, CKD, and obesity. So those are the very factors that we have to focus on post-transplant recipients as well, managing their high blood pressure, managing their diabetes, managing dyslipidemia in these patients. And unique to these patients, there will be some influence of immunosuppressive medications playing a role in their blood pressure, diabetes, and high cholesterol levels. And I will go into that shortly. We will also focus on smoking cessation, continued weight reduction, and as well as CKD. So I might want to remind you all that deceased donor kidney transplant definitely provides survival benefits. So does living donor, living related and unrelated kidney transplantation. However, you are going to see a lot of these, majority of these patients after deceased donor renal transplant having CKD, at least stage 2 or 3 or even worse. So you have actually afforded them a survival benefit much better than being on dialysis, but you have not actually completely made them normal in the sense they continue to have chronic kidney disease. So the prevalence of metabolic risk factors continue to remain in these recipients. And this is data from liver transplant recipients, but it is the same for our kidney transplant recipients as well. So the prevalence and risk of obesity is very high. Why is that? And when patients are on dialysis, they're largely in a catabolic phase or mode. The moment they're transplanted, they enjoy a new graft and they become very anabolic. We do blame steroids to some extent, but nowadays, most likely the steroids are reduced to 5 milligram, which is just about what your endogenous steroids would be. So the main cause of gaining 15 to 30 pounds in the first 1 year is mostly related to they don't have any food restrictions anymore and they are in an anabolic phase. So this is something that primary care physicians will have to watch out for. Then the second one is diabetes. So remember, the leading cause of kidney failure is diabetes. So that continues to remain in these patients. And a large number of these patients also become diabetic. It's called new onset diabetes after transplant, or PTDM. It's a combination of risk factors. So they develop glucose intolerance as a result of type 2 diabetes, as well as calcineurin inhibitors playing a role in islet cell injury. The blood pressure. So I have seen practically if a patient has had hypertension, they usually require less number of medications after transplant. However, some patients tend to at least require 2 or more agents to control their blood pressures after transplant. Now, CNIs also play a role in some patients being hypertensive post-transplant. Dyslipidemia. Depending on the immunosuppressive agents used, dyslipidemia continues to be a problem. Therefore, all these metabolic risk factors are continuing to remain, and also they are sometimes modified in the post-transplant phase. So the pre-existing hypertension, diabetes, immunosuppression-related factors, graft dysfunction, and CKD-related cardiovascular disease are all playing a role in these patients having an continued increased risk of cardiovascular mortality. I want to let you know that a lot of this data is coming from very few trials. There are no good or large randomized control trials in transplant recipients. So management of hypertension in renal transplant recipients. Kidney transplant recipients have a markedly increased risk of premature cardiovascular disease and death, and we already talked about it. Hypertension is an established risk factor for CVD in this population and is associated with reduced graft survival. There is convincing data on the role of blood pressure and cardiovascular risk from a post hoc favorite trial. And I will show you that trial, and it's one of my favorite studies. And I actually look at this in my practice. I do this in my practice. But there is a lack of RCT and data on specific agents to treat blood pressure, or there is no target blood pressure goals in these patients. And that would benefit graft outcome. So this is the post-hoc analysis of the favorite trial. And it's interesting to see that when you look at, and this was a very large study, it was about 3,500 patients. When you look at the systolic blood pressure, with every 10 millimeter increase in systolic blood pressure, the composite endpoint of mortality and the hazard ratio of cardiovascular disease goes up. So a systolic blood pressure over 140 is detrimental to post-transplant detrimental to transplant recipients. However, when you look at the diastolic blood pressure, it actually swings in the opposite direction. So you can see that every 10 millimeter decrease in diastolic blood pressure below 70 is detrimental. And why is that? This is because 2/3 of your cardiac cycle is in the diastolic phase. So this one graft that you have, which is your precious kidney, is dependent on flow both in the systolic and diastolic phase. So what is the goal of blood pressure in these patients? The guidelines are mostly that you see in KDOQI guidelines and NKF guidelines suggest that we do want to keep their blood pressures in the 130/80s, but also be mindful that some older kidney transplant recipients are going to have a widened pulse pressure. So their diastolic blood pressures have also to be maintained in the above 75 range. Sometimes that is hard. So what is the drug of choice? Dihydropyridine calcium channel blockers are my preferred drug of choice. Why? Because they counteract the vasoconstrictive effect of CNI and have a favorable effect on graft outcome. So what would be my first choice? I always go to Norvasc or amlodipine and or nifedipine extended release. However, the non-dihydropyridine calcium channel blockers, such as verapamil or diltiazem, can be used, but they have a very significant potent drug-to-drug interaction, which you can use if you want the CNI levels to be maintained in rapid metabolizers. And I will show you I would be showing that. Now, what about ACE inhibitors? I tend to shy away from ACE and ARB, but that's just me. ACE inhibitors, I do use it when proteinuria is over 1 gram. And this is because you have one graft, and they tend to be anemic from the usage of Cellcept or Myfortic or even Rapamune. And I might even aggravate that if I use ACE and ARB. And the other reason is, the anastomosis. If I think that it's an older donor kidney and there might be a chance of anastomotic stenosis, then I shy away from that as well. However, the KDOQI does recommend that measuring blood pressure at each clinic visit is a must. We suggest maintaining blood pressure in the 130/80 or less than range. To treat hypertension, any class of antihypertensive agent can be used. When urine protein creatinine ratio, protein excretion is more than 1 gram, then consider ACE or ARB. Now that's your KDOQI guideline, and this was my personal experience. The incidence of and cost of new onset diabetes among US waitlisted and transplanted recipients. As you can see on the right side, there is an incremental increase of diabetes after transplant, and that being worse for those patients on tacrolimus versus cyclosporin. So what are the risk factors generally in the post-transplant setting? African American race is a risk factor of new onset diabetes after transplant, obesity, and CNI, as well as mTOR inhibitors. They all increase your risk of post-transplant diabetes. So what do we do? It's advisable to screen these patients every 3 months in the first 1 year and then yearly thereafter. And if you do recognize that they have a glucose intolerance or they have become what we call NODAT, then you want to adopt the choice of insulin or oral hypoglycemic agents have the same restrictions for comorbid conditions in the general population. The benefits and harm of altering the immunosuppressive medication regimen is unclear. Therefore, I don't change the dosages or switch calcineurin inhibitors. And mind you, you want to keep the A1Cs between 7 to 7.5. In asking what is the appropriate screening tool, I use HbA1c after 3 months. And then I usually use the fasting blood glucose levels in those patients who are less than 3 months post-transplant. And in a diabetic transplant patient, yes, we also want to maintain their blood pressures in the less than 130/80, spot your PUC ratios annually, and you want to keep it less than 500, less than 200. You also want to make sure that their LDLs are within goal, which is less than 100, and the BMIs is also appropriate. So here you go. What do we do about dyslipidemia in renal transplant recipients? So the goals are pretty much the same as in general population. You want to keep the LDLs less than 100, triglycerides less than 150, and non-HDL cholesterol less than 130. This is a good trial showing the use of fluvastatin, and this was a large patient population, and it was a randomized controlled trial lasting about 5 to 6 years, and it was intention to treat analysis. The composite endpoint of coronary intervention and or MACE. And what they found is this study did not reach the composite endpoint. However, you can see that the effect of fluvastatin on cardiac outcomes in renal transplant recipients showed that those patients who were on a statin definitely benefited from having less non-fatal MI or fatal MI. Therefore, the KDOQI dyslipidemia recommendations, again, the kidney transplant recipients, if they have a fasting triglyceride level of more than 500 and they are on an mTOR inhibitor, I would suggest that you would change that. Lifestyle changes and a triglyceride lowering agent should be provided. Now, my goal for LDL is usually less than 100 and non-HDL cholesterol less than 130. You can use any statin. If you're using Lipitor, reduce the dose by 50% because the exposure of statin and CNI can cause significant myopathy. I don't usually go about 20. If additional lowering of triglyceride is indicated, then you can always use Zetia, fish oil. I have avoided gemfibrocin and niacin. Now, regarding osteoporosis, this is a tricky place. There are no good trials. Fracture risk after kidney transplantation is believed to be or perceived to be higher than general population, but I have not seen this to be the case in 18 years of my practice. Why is that? Post-transplant bone mineral disease is multifactorial. The patients come with, so they are transplanted and they still have existing bone mineral disorder of chronic kidney disease. My worry is always persistent hyperparathyroidism post-transplantation, and that can sometimes augment the CKD MBD. Now, immunosuppression induced, such as steroid-induced chronic bone mineral disease is, there's no data on that. There is insufficient data to identify who will benefit from treatment or to suggest any bone-specific therapies. What I would do is I usually, if someone's graft is good, then I'm very happy. I've never seen anyone have a fracture. As a primary care physician, I'm sure you would want, and Kedoki recommends, to do bone densities every month for up to 2 years. And then if the graft is functioning fine, you don't really have to do that. What about cancer risk? So I'm sure you're all thinking that post-transplant recipients have a high risk of cancer. Let's go and understand what type of cancer is high in incidence in these patients. There are several national cancer registries. The Surveillance Epidemiology and End Results Program is a very nice cancer registry. You can go in there and understand cancer statistics of almost any type of cancer in the general population. For example, I just pulled up prostate cancer. As you can see, the 5-year survival of prostate cancer is almost 98%. So it will give you, and this registry will give you estimated new cases in that year, percentage of new cases, and also death related to cancer mortality. Now, there is a renal transplant recipient specific registry. It's the Israel Penn International Transplant Tumor Registry. This is a self-reported registry, and you can see cancer after transplantation in all categories. End-stage renal disease and cancer, kidney transplant cancer, and they have great publications as well. I have often called them to advise me on cancers and how to manage those recipients, and they're very receptive. So this is one of the cancer registries that gives us most of the data of post-transplant cancer, at least in our country. Risk of cancer in ESRD versus general population. So there is an increased risk of cancer in end-stage kidney disease patients compared to the general population. This is the New Zealand and Australian registry. I usually don't look at that because they have a very high risk of non-melanoma skin cancers, and therefore the cumulative burden of cancer post-transplant tends to be very high. But I just wanted to show you that there's standardized incidence ratio of cancer after dialysis is increased. That is as a result of your surveillance camera is down in dialysis patients. So uremic milieu often tends to mar your immunity, and therefore you have a higher risk of infections and cancers. And the same is true for after transplantation, there is a higher risk of cancer. Now let's understand what type of cancers are high in transplant recipients. I want you to know that the risk of infection-related malignancies is increased. So the standardized incidence ratio compared to general population is high for those cancers which are virally mediated. For example, lymphoma, PTLD, and human papilloma-related viruses. So this is because immunosuppression is making the immune system or the T cells unable to detect viral replication. Therefore, your cancers that are virally mediated as a result of EBV virus or hepatitis C virus or human papilloma virus is high. But what about the non-infection related malignancies? So the non-infection related malignancies such as prostate cancer, you would see is actually lower than in general population. That's because there is a lot of screening that goes on before the transplant. And if you look at any of these solid organ malignancies, they are the same, almost comparable to general population, except for renal cancer. And why is that? Well, this is because you know that kidney patients on dialysis have acquired cystic disease. And if they have been on dialysis for more than 3 years, they do have these acquired cysts of end-stage kidney disease turning into cancer. So I would have a keen look at ultrasound or any imaging that is done on patients who've been transplanted after remaining on dialysis for more than 3 years. But if you look at any of the other solid organ malignancies, then you don't have an increased risk. Therefore, I would conclude that there is minimal increased risk of common tumors such as lung, breast, prostate, colon, but virally driven tumors have a very high risk, such as vulvar, anal, non-melanoma skin cancers, and PTLD. So what would you recommend? I would screen for the following cancers as per local guidelines for the general population. So that is, just make sure that your patients at every visit, they have had their routine general surveillance done at the appropriate time. Now a little bit on pregnancy and transplant. So fertility is restored almost 6 months after transplant. So delay pregnancy until the first 1 year, and that's because you want the graft to be stable. You don't want any rejection, because if you have a rejection while you're pregnant, there are very little drugs that are available that are safe to use in pregnancy. The European best practice guidelines suggest delay pregnancy until 2 years, but I have only recommended 1 year with a stable graft. So how safe are these patients? Obviously, this has to be, it's a complicated pregnancy, it's a high-risk pregnancy, and it has to be a multidisciplinary team. So they do have a high risk of eclampsia, preeclampsia. They have a high risk of preterm birth and low for birth babies and C-section. So knowing that, what are the drugs that are safe in pregnancy? Azathioprine has been long time in the market, in the field, generally safe first-line immunosuppressive agent in pregnancy. Calcineurin inhibitors are safe, are considered safe, except that they may have an early incidence of gestational diabetes, and sometimes I've seen low birth weight in the babies. Prednisone is considered safe. Rituximab has no teratogenicity. However, they can cause some neonatal B-cell depletion, so possible long-term neonatal effects are unknown. I would avoid mycophenolate mofetil because they have high rate of fetal loss, congenital anomalies, and transition to alternate agent. So it has to be a planned pregnancy. That's something you want to tell them. You want to transition if they're on MMF or MPA transition, and have a window of at least 12 weeks before the planned pregnancy. Cyclophosphamide must be avoided, has high risk of fetal loss and congenital anomalies. Use in late pregnancy is okay. Now, what about mTOR inhibitors? They have impaired spermatogenesis, so if a man is trying to get pregnant, then you can definitely remove mTOR. But for women, I've usually not done anything. I've just kept them on mTORs. Belatacept has limited human data. Special consideration, so in pregnant women, you can advise low-dose aspirin. Lower CNI levels are often seen in pregnancy, and that's because of the increase in plasma volume. Adjustment to their dose by 20 to 25% may be needed. If C-section is required, then avoiding injury to the ureter of the transplanted kidney, which may be in the way and anterior to the uterine artery, breastfeeding. So this has been an area of debate. I know that there are low levels of TAC, azathioprine, prednisone detected in breast milk, and yes, the baby will be exposed to that, but it's deemed to be relatively safe. Now, just a quick review on vaccinations. So any inactivated vaccines are safe, but any live attenuated vaccines, you should give them before transplant. And if you're giving a live attenuated vaccine, wait at least 4 weeks before transplanting. What about pneumococcal vaccine? There are 2 types of vaccines. So the PCV13 is a conjugated protein vaccine. And believe it or not, in post-transplant patients, this is more effective. For some reason, it gives a better T cell response and also memory B cells. But then this has 13 more valency. So I would give PCV13 to post-transplant recipients, and after 8 weeks, give them a PPSV23, and this you can give every 5 years. So now, all these live attenuated vaccines, MMR, we check the serologies pre-transplant, and if they're not immune, then definitely we'll have to give the vaccine and wait for 4 weeks. So this is only suggested pre-transplant, varicella vaccine only pre-transplant, zoster vaccine is live attenuated, so you can give it pre-transplant. But this has been given, there are two kinds of zoster vaccines, and the recombinant one it does not have a lot of data, but both of them have been given post-transplant and usually don't have any problems. So from a PCP standpoint, you want to avoid the nasal influenza, the live attenuated, but the other one is perfectly fine, and do give it to them as needed. I would just avoid MMR, the live attenuated varicella, plus or minus, and any of the live attenuated vaccines should not be given, but any of the inactivated vaccines can be given. What about COVID-19? We strongly recommend that all eligible transplant candidates and recipients should be vaccinated, preferably before transplant. But this is a new recommendation that the panel, the infectious disease panel of American Society of Transplantation, routinely is recommending any COVID-19 vaccine that is available, and the routine provision of a booster after the primary series with variant appropriate vaccine. For example, if they initially received a 3 vaccine series, then you can give them the booster, the 1 booster. But if they received the 1 vaccine for the primary vaccination, then give the booster. So when do you give the booster? It can be given whenever it's available, at least after 3 to 6 months after the primary vaccination. What if your patient had a COVID infection? Then wait for at least 6 months before you start vaccinating them. They suggest using any WHO-approved vaccine rather than selectively choosing a specific type, and receiving a single dose rather than a double dose of COVID-19 vaccine booster. We suggest vaccination before transplantation when possible, and that's so really for COVID-19. In solid organ transplant recipients, we recommend providing additional COVID-19 vaccine boosters beyond a primary series. So they used to be given 3 vaccines. I mean, that was the initial recommendation as a primary series. So if they receive 3, then give the 1 booster. And type of vaccine does not matter. If they suggested any currently available approved vaccine as opposed to selectively choosing the type of vaccine. And then vaccine dosing, they suggested providing double dose as compared to the standard dose of a given vaccine. And the timing usually is this, it can be given even 1 month after transplantation. A little bit on the side effects that you might see in some of your patients. If they're on Recpients, everolimus, one of those mTOR inhibitors, if they come with it can present as interstitial, like COPD or acute BOOP-like syndrome, interstitial lung disease, anytime, dyslipidemia, they initially exposed, they might develop mouth ulcers, impaired wound healing. So when your patient who's on Recpients and they're going to have a plan for a surgery, then you're better off withholding that and then restarting it after wound healing. Proteinuria is one of the side effects. They have podocyte cytoskeletal toxicity. So I always monitor proteinuria. They can develop lymphocytes, anemia. CellCept or MPA, usually you will see patients initially when they're at a higher dose coming with GI side effects such as diarrhea, nausea, vomiting. You will see bone marrow suppression at higher doses, especially soon after that you treat them for any right after transplant or after any escalating doses after a rejection treatment, leukopenia, neutropenia, anemia. So remember, these are, when you see leukopenia, you want to make sure that that it is secondary to, your differentials are going to be secondary to immunosuppressive medications, secondary to prophylactic medications such as Bactrim or Valside, and or secondary to opportunistic infections. So whenever you add or take away medications from a transplant recipient, please be aware that you may want to collaborate with your transplant team. Calcineurin inhibitors, as I said, verapamil and cardizem are very potent inhibitors of the main metabolic pathway for CNI is the cytochrome P450. So the CYP3A, CYP3A 4 and 5 that is present in the GI tract as well as the liver are the enzymes that metabolize your calcineurin inhibitors. So if you bring in a strong inhibitor of the CYP3A, then your enzyme, the trough levels are going to go high and you're going to have toxicity. Most are reversible competitive inhibitors, therefore, it is reversible. You will see the effect immediately after 1 to 2 doses, but you can always reverse this within 2 to 3 days of stopping the drug. So what are those agents or medications that can inhibit the CYP3A? So the antifungals are very notorious, even diflucan, Bori, posaconazole, itraconazole. So bear in mind, if you have a transplant recipient, you're going to put them on antifungal, you want to collaborate with your transplant team. Macrolide antibiotics, azathioprine is fine, but if you are going to go to give them erythromycin or clarithromycin, they will increase your CNI levels. Now, the protease inhibitors are also, they can increase, they're very potent inhibitors to the point, some of these patients, if you're on ritonavir, they only require 0.5 mg of Prograf once a week. So it's that much of an inhibitor. And grapefruit juice, we always let them know not to drink it. This is, transplant team will have them be aware of this. Now, what are the inducers? Anticonvulsants, anti-TB drugs, and the NNRTIs, they are inducers. So what would happen? They will induce this enzyme and you would have subtherapeutic level and therapeutic failure leading to transplant rejection. Thank you for your kind attention.
Before we wrap things up today, I just want to briefly highlight some of the benefits of telemedicine in renal transplant care. As summarized in this figure, I'm just going to quickly explain, as we know, kidney transplantation is the treatment of choice for patients with advanced kidney disease who are medically and surgically fit to undergo this procedure and have a reasonable life expectancy. It provides improved survival and quality of life for recipients and overall cost savings to the healthcare system. The process of undergoing kidney transplantation involves several phases of care, including the pre-transplant referral and evaluation, the waitlist management, and finally the follow-up. In all phases of care, transplant centers interface with candidates and recipients who live across a wide geographic range, and many patients travel significant distances to get to a transplant center. In the United States, 41,077 candidates were added to the waiting list in 2019, and 23,401 received a transplant. There are approximately 220,000 prevalent kidney transplant recipients and 250 centers actively performing these transplants. With this continually growing patient population and a limited number of transplant providers, transplant centers are in need of innovative models of healthcare delivery that, one, allow them to reach and monitor candidates and recipients, particularly those that live far away, and two, improve the utilization of the transplant center resources. Telemedicine has been successfully used by numerous specialties, and its utilization in the field of kidney transplantation has been lagging. Telemedicine has the potential to affect and improve the delivery of kidney transplant care through the following. 1, replacing or supplementing in-person visits with virtual visits through TVC or telehealth video conferencing. 2, electronic consultation. And 3, and finally, remote monitoring and provision of education through mobile technology. In this figure here, we focus on TVC and highlight opportunities for its use through the various phases of transplant care.
Okay. So I just wanted to I had noticed a couple of updates that are important to bring up with regards to the vaccination recommendations, primarily for pneumococcal vaccination, as well as for for shingles vaccination as well. So the update mainly is from the Prevnar 13 and pneumococcal vaccination to now it's the Prevnar 20, which is Pfizer vaccine, and then there's the PCV 21, which is the Merck vaccine, are recommended so far one time only once the patients receive those vaccinations. And then also we have the Shingrix vaccine, which is the update from the Zostavax, which is the live vaccine. So the Shingrix is the recombinant vaccination, and so it's considered much safer and shows an improved effect for immunity. And so those are the updates. Those are recommended in solid organ transplant individuals. So I just had noticed those with regards to the vaccine, and I did want to provide that update. And also, by the way, thank you for clarifying the pronunciation tacrolimus instead of tacrolimus. Thank you.
We're opening up the floor for questions. No.
Does our department use telecommunication with patients or physicians?
It just helps to heal.
You use telecommunication to try to assist management.
I have not had a chance to so far. I think that's what we are trying to accomplish with this, that, more and more patients are going to come to primary care physicians, and there is no reason why they cannot manage the patients with just collaborating very closely with transplant professionals if needed.
That sounds easy, but I would be pretty reluctant to be taking care of a transplant patient.
No, the stable transplant. Hello? Can you hear me? So, Dr. Pixley is going to tell you that he has patients who are on Cellcept and tacrolimus for lupus or one of the rheumatological conditions, and these patients show up to PCPs and we don't think twice about them, right? So it's almost considering these patients as, yeah, they are on immunosuppressive medications, but they have a kidney graft, but that's fine. And the discussion that we had today is how do you manage those patients? Pretty much like your general population, with just a few emphasis on drug-to-drug interactions, which are very important to bear in mind, that might affect the graft outcome. And then, of course, the vaccination schedules and generally taking care of their cardiovascular risk. I think the primary care physicians should know that they can reach out anytime they want, but these patients are not going to be served just by transplant professionals. First of all, there's a lot of them out there in the community, and that exceeds the capacity of the transplant team. And honestly, transplant team are not prepared, or they're not trained even to take care of primary care needs. Whenever I have to do the 2 weeks of internal medicine, I dread, like I absolutely don't like it because I'm not a primary care physician. So the transplant patients going to PCP is the right approach, with their occasional coming for immunosuppression monitoring.
Have you had women get pregnant and go through it?
Quite a few. And all of them had beautiful babies. But they were always planned pregnancies. I would talk to them before transplant, and they will wait 1 year, and we would have a team of high-risk pregnancy professionals involved, and I would have switched their immunosuppressants to have them on Prograf, prednisone, and azathioprine, and wait for about 12 weeks and go ahead.
Just a quick comment, Dr. Zachariah. Thank you very much for a very great presentation. I think, we are lucky to have your expertise here. As a surgeon, every now and then we will operate on a patient who had a previous, kidney transplant, and sometimes we worry about, the drug-to-drug interaction. We give them antibiotic. We all know they are in immunosuppressant program and so as you mentioned. On those cases, though, my question though is, do we need to get levels, for instance? Like if they are in the ICU or in the secure MICU, do we need to get those program and so levels?
Yes. So I don't know if um, all the floor nurses are aware of timing, because I've seen most of the time we draw a level, but they're random level. They're not a real trough level. So yes, in case you have to add any medications, you just keep monitoring their levels. And as long as you have maintained levels, now mind you, if you have a patient who has sepsis and you are taking away the immunosuppression from them. So if someone has full-blown sepsis, then obviously we're going to stop their tacrolimus. We're going to put them on stress dose steroids until they are out of that picture. So I don't usually get levels in the ICU because they are probably not going to be on their triple immunosuppression. They are septic, so that I would have their MMF on hold, tacrolimus on hold until they are out of that.
Especially if they're have gastrointestinal surgery, the absorption level will be
Yeah.
kind of erratic too.
Yes. Any other questions?
Thank you, Dr. Sakraya, for an excellent lecture. And thank you, Christian and Dr. Natarajan too. I appreciate all of you coming in, and kindly use this activity code to check in to get your CME credits. If you have any other questions, please let us know. Thank you.